Good afternoon, everyone. Thanks for joining us. We're going to give it a couple minutes to fill the room up here. Thanks again for joining us, everyone. We'll give it a minute to fill the room here. We'll give it about 30 more seconds here to fill the room. Thanks for joining us, everyone. Good afternoon or good morning, wherever you're joining us from. And thank you for joining us once again for our weekly Wednesday webinar series. My name is Brett Spitali. I'm the Vice President of Advancement here at the National Hemophilia Foundation. Today's webinar, we will discuss the evidence for shared decision-making for hemophilia and gene therapy. Please feel free to ask any questions you may have by using the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will present to our speaker after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, May 26. Today, I'm joined by Dr. Courtney Thornburg, who is the Medical Director of the Hemophilia and Thrombosis Treatment Center at Rady Children's Hospital in San Diego, and the Director of the Hemostasis and Thrombosis Research Program. Thank you for joining us today, Dr. Thornburg, and I'll now turn it over to you to get us started.
Thank you, Brett, for the introduction, and thank you to Dr. Valentino for the invitation to present at this Wednesday webinar on the topic of evidence for shared decision-making for hemophilia gene therapy. So the learning objectives for today are to understand the evolving hemophilia treatment landscape and need for resources for informed decision-making, to understand key concepts of patient education and shared decision-making for gene therapy, to learn about results of studies on patient preferences and shared decision-making for gene therapy, to understand plans for development of shared decision-making tools in collaboration with the World Federation of Hemophilia, and to identify resources for healthcare provider education and shared decision-making tools. And so as we start the discussion of shared decision-making, I think really the key point is achieving patient goals and matching treatment decision with patient goals. And I really like this figure that was in a publication by Mark Skinner and colleagues that was called Achieving the Unimaginable: Health Equity in Hemophilia. And it represents that as you have evolution of therapies that provide higher levels of hemostatic protection against bleeding, that not only do clinical outcomes improve, but more importantly, patient relevant outcomes improve. And so, people with hemophilia then can have achieve goals related to work, career, and family without restriction, have more unrestricted lifestyle, not depend on specialized healthcare, and really, try to achieve optimized health and well-being. And so I just want to talk a little bit then about approaches to hemophilia therapy in the current state, and really focus on prophylaxis for prevention of bleeding. And in this figure, we see factor levels and hemostasis for 4 different treatment classes. And so we start with the standard half-life factor. And so with this, which has been used for many decades to prevent bleeding, we see that with pretty frequent intravenous infusions, then we have troughs and peaks of the factor levels. And this has worked very well, but has more burden due to the type and frequency of treatment. And so then More recently, there's been development of extended half-life clotting factor, which is still intravenous, but you can achieve higher factor levels with fewer infusions. And then we've moved to the non-factor therapy, and particularly what's approved now is a factor VIII mimetic emicizumab, and this has advantage of longer half-life and subcutaneous administration. So although we're not measuring factor levels, we can achieve their sustained hemostasis with less burdensome treatment. However, there's still a ceiling effect in terms of the factor VIII mimetic, and you still need factor, as needed to treat bleeding or with injury or surgery. And so still room, potentially for improvement. And this brings us to gene therapy with really the goal of having sustained factor production so that, people no longer need regular treatments to prevent bleeding or even potentially for injury or surgery. However, gene therapy has more significant side effect profile, or at least potential for side effects, and there are remaining questions related to factor level achieved and durability of response. So with this evolving treatment landscape, there's really great opportunity for more education of both people with hemophilia, their families, and providers, and to have informed discussions. And so some key considerations for patient education and decision-making are that we want to gauge whether a patient already knows about gene therapy or other therapies and level of interest or activation. So is someone ready to make a change or even to learn about a new treatment option? And then, if they are interested, and to educate patients, clear up misinformation or misconceptions, answer any questions, determine health and gene therapy literacy, of course, language preference, ask how patients prefer to learn, provide additional educational materials depending on learning preference. There are a number of different formats, so this could be written, video, podcast, webinar like we're doing today, and a number of excellent resources in the community, including NHF, HFA, WFH, ISTH, which is the International Society for Thrombosis and Hemostasis, and then industry partners. And then, as part of the discussions and education, we want to establish who else should be involved in decision-making. Is that a family member, partner, or other? Consider connecting with someone who has already undergone gene therapy, though recognizing that there can be variability in outcomes. And then what we'll talk a lot about today is utilizing shared decision-making tools, and in particularly, they should include assessment of patient goals and preferences. And realizing that this is not going to be just a one-time discussion, but depending on the person will may require different numbers of discussions and may take a variable amount of time. And so I like this description of gene therapy, and education on these new therapies is really key. And so this story of gene therapy is based on a package. So we start with what's the delivery package, and we say that a viral vector is like a delivery package that is designed to transport a good copy of a gene to its destination. In this case, a good copy of the clotting factor gene to the liver cells of patients with hemophilia. And then we go on to say, okay, well then what's in the package? How is the package delivered? What happens to the package upon delivery? So then here we say that the contents of the package are kept inside the liver cells and the packing materials are recycled. It brings up a point of potential immune response that then the packing material is recognized as foreign, and so you learn that you can get the package delivered once and have it work, but subsequent packages won't be successful. And so now we'll talk about the shared decision-making tools and what is shared decision-making. And this is really a partnership between the patient and family and the treatment team. And the shared decision-making tools are designed to help patients and clinicians participate in making specific choices among healthcare options. And there is evidence that shows that these tools increase knowledge, accurate risk perceptions, and satisfaction with decision-making. And so we've aimed to develop shared decision-making tools for hemophilia therapies, including gene therapy. And we've done this through patient surveys and patient provider interviews. And I'll show you some work related to development of a clinician shared decision-making tool using a specific framework, and also discuss some collaboration with the World Federation of Hemophilia for a patient shared decision-making tool. And then ultimately, the goal is then to test, evaluate the tools and implement them for clinical practice and use. And so this framework is shown here on the left, and it starts with decision needs, so assessing decisional conflict or uncertainty about the decision. I mean, sometimes you have a medical decision or some other decision in life, and it's just clear cut, like you have appendicitis and you need surgery to take the appendix out. But as I mentioned, with the hemophilia therapies, we have a number of options, and so there may be some uncertainty in terms of what the best choice is. And then also within the decisional needs are knowledge and expectation, values, support, and resources, what the type of decision is, and how personal and clinical characteristics influence decision-making. And then the goal is really an informed values-based decision. And in terms of decision, it may be to continue the current treatment, to switch to a new treatment, or to continue getting more information, having discussions, and delay the decision until later. And so in order to meet all of these needs, decision support is necessary and includes clarifying the decision needs, providing facts and data, having discussion that helps to clarify values, and then along the way monitoring progress and seeing if the patient's getting the education that's needed, and there's sort of the process to see how the again, the patient treatment goals align with different therapies. And then, so here on the right is just a sort of generic example that's provided, and you start at the top with clarifying the decision. So what decision do you face? What are the reasons for making this decision? When do you need to make a choice? Sometimes in medical care, it's emergent, it needs to be made very soon. On the other hand, for hemophilia prophylaxis, if you're doing fairly, well, then you can certainly have time to make the decision. And then, thinking about how far along you are with making a choice, is this something you've never thought about at all? Or, all the way to, okay, I'm ready to make a choice or a decision. And then the lower part of the figure then shows how you can sort of list out, the options, the different treatment choices, and the benefits and risks that or that you want to learn about. And then the rest of it is sort of matching up, okay, well, how important is this particular benefit or this particular risk to you, and how do all the treatment attributes align with your health goals? All right, so now I'll get into some of the research, and I'll talk about first two studies that were in partnership with the National Hemophilia Foundation, Community Voices in Research. And you may know this is an online platform for patient-powered research, and people sign up for this and then can get complete surveys and get study invitations. So through this collaboration, then study invitations were sent to the population of interest, and these are English proficient men with severe hemophilia A or B. And so there are actually 232 men that received the email, and then if they agreed through sort of online consent affirmation, then they completed the survey. And questions included sociodemographics, clinical characteristics, including current hemophilia treatment, learning preferences, prior knowledge and experience with novel therapies, gene therapy decision-making preferences. And then respondents who previously received gene therapy also answered questions about their gene therapy experience. And so we had 104 males with severe hemophilia, so this is 45% response rate, and as surveys go, actually quite good. And the average age was about 40 years, with a range from 18 to 76. 75% white, 65% non-Hispanic, about 50-50 in terms of commercial versus government-issued insurance. About 85% had higher education, and 64% were employed or a student. And then in terms of the types of hemophilia and treatment, so we had 67 with hemophilia A, 9% had gene therapy. About 84% were on prophylaxis with either clotting factor or factor VIII mimetic, and then 7.5% were on demand. And then there were 37 with hemophilia B, about 5% who'd had gene therapy, 40% on prophylaxis with clotting factor, and then 54% on demand. And when asked about satisfaction with gene therapy, 87% who'd had gene therapy were satisfied with their decision. And then in terms of prophylaxis, 100% with hemophilia A and 88% with hemophilia B were quite a bit, or moderately satisfied with prophylaxis. And we thought it was important information to gather in terms of thinking about who might be interested in learning about new therapies. And so this table has more information about satisfaction with prophylaxis, and really the take-home point is that although majority were satisfied, or quite satisfied with the current prophylaxis, you see in sort of the bottom row related that asked about interest in switching to a different type of prophylaxis or treatment. There were still a number of participants who are interested in potentially switching, ranging from 20 to 30% for those on clotting factor prophylaxis, and 14% on the factor VIII mimetic. So then thinking about, that we have a population maybe interested in learning about new treatment options, we want to know what's being done. Are people talking about new treatment options with their team? And 80 did report that they talked about new treatment with the treatment teams, mostly at annual clinic visits, although about 30% at every clinic visit. And then in terms of the types of treatments discussed, certainly the extended half-life clotting factors were discussed for those with hemophilia A and B, the factor VIII mimetic for the hemophilia A, since it's only indicated for that type. Fewer had discussions about research studies for new subcutaneous treatments, though quite a few had discussions about gene therapy, including over 90% for hemophilia B. So good to know that treatment teams are engaging patients in discussions about new therapies, but always room for improvement. And so we talked about learning from the treatment center, and when we asked how you most like to hear about hemophilia and treatments, the top choice was the Hemophilia Treatment Center. However, other choices were on my own, from other people with hemophilia taking the treatments, National Hemophilia Foundation, my specialty pharmacy, and then some other, which were scientific meetings and peer-reviewed journals. So only some of the participants with who are very engaged in learning about new treatments. And then when we asked about to name all sources for learning about hemophilia, then it was a combination of people, online education platforms, including NHF, HFA, and WFH websites. And then, less so that were reported for social media, although the top social media sources were Facebook and YouTube videos. And so I think this is important to know in the community in terms of where people like to get information. And so to make sure that, valid and good sources of information are available on all the different platforms. So then we asked about familiarity with gene therapy and those who had not had gene therapy. And 71% were somewhat familiar, 23% very familiar. So few who really had not heard about gene therapy. And then we asked more in terms of perception of gene therapy in the treatment options for hemophilia. 35% that it should be offered to everyone, 41% useful to some people, 20% or 21% felt like doctors should decide, and then 3% thought that it should not be a part of the treatment. So, varying perceptions in the community, which is quite common, especially for new therapies. And so, in order to inform, education needs and what to have in shared decision-making tools, then we asked about sort of key gene therapy attributes that people want to know about. So the top ones were efficacy, safety, and mechanism of action. And then, less chosen, but still significant, were eligibility, so who can get it, the cost or insurance coverage, what's required for follow-up monitoring, how side effects are managed. And a few people put in some free text, wanting information on long-term effects, how long does it last, are other people using it, and if so, how they are responding. And then just overall expected outcomes. And these data were similar to another study that was done in the Netherlands, and this is the Paving Study. And as part of this, there were interviews and surveys with 20 persons with hemophilia, 80% severe. And the top 10 attributes important to decision-making about gene therapy were effect on annual bleed rate, factor levels, so that would be efficacy, uncertainty about long-term risks, so safety, as well as impact on daily life, the probability or chance that prophylaxis can be stopped, possibility of undergoing major surgery, how it's given, the probability of liver inflammation, mechanism of action, and dose frequency. And then there was another study that was conducted by a different group, but also through the Community Voices in Research. And this is included a discrete choice experiment. So this is basically when the participants are asked to indicate preferences related to different scenarios. For example, if you think about the dose, frequency, and durability, would your preference be to have administration multiple times per week versus one-time treatment with lifetime durability? And so the participants go through these different scenarios, and then the top gene therapy attributes are identified. So that is shown here. So on the bottom is the relative importance score. So the top two were effect on overall annual bleeding rate, and then dose frequency and durability. Other important attributes were the uncertainty regarding safety issues, impact on activity of daily life and physical activity, transformative or mental health impact, and post-treatment possibility to undergo minor surgery without need for factor therapy. So maybe less reliance on sort of specialized treatment center. So then back to our survey, we asked reasons to not consider gene therapy as a treatment option. And themes here were sort of lack of data, wanting to wait to see what happens, as well as satisfaction with current treatment, as we discussed before. And then importantly, there was some lack of knowledge or opportunity. And so a number of people said, I don't know much about it. It has not been offered to me. I've never heard it. And so, in order to really achieve health equity, we want to make sure that all people with hemophilia who may be eligible have the opportunity to learn about gene therapy and, all the other treatment options and discuss with the treatment team. And then we asked about some other reasons for not considering gene therapy. And so these were grouped into ethical, risk-benefit association, or risk-benefit ratio, risks, efficacy, eligibility, and burden. And so, one person said, at my age, with my life expectancy, I might conclude that the benefits do not outweigh the risks. So it's thinking about personal characteristics that might influence decision making. And then we had a question about what things worry you about gene therapy, and side effects, as long as long-term monitoring and follow-up were the top selections. And again, there was concern from some participants that gene therapy is very new. They don't know anyone who's tried it. And so, highlighting the fact that, need for more education and incorporating, new treatment options into discussions at, different clinical or clinic visits. And then, again, some participants wrote in some other worries about gene therapy, sort of grouped into the same categories as before. Some of the concerns in terms of risks were related to liver cancer, or impact on liver if you already have hepatitis. And this is particularly since the current gene therapy is targeted to the liver. And then in terms of efficacy, some concern about this being sort of one shot, not being able to redose if you don't have durable response, and then not being able to retreat. So very valid considerations. So then we asked about likelihood of considering gene therapy, and grouped responses into low likelihood versus high likelihood. and 27% were on the low likelihood, including 5% who indicated they wouldn't consider it at all, and then 73% who were in the high likelihood group, including 18% who indicated they'd be the first on board. And then we did an analysis to see if there were any associations with the higher likelihood of considering gene therapy, and these included Hispanic race, government-issued insurance compared to commercial, and lower satisfaction with prophylaxis. And so I think as gene therapy is implemented and we have more of actual shared decision-making discussions, these associations will need further study. And so here we have a summary that indicates the sources of information that people use to learn about new therapies, the personal characteristics and worries that could influence decision-making, and then the key information needs. All right, so then the second study was also conducted through the Community Voices in Research with a similar patient population. This was an interview study. So for those who agreed to participate, they talked with a research coordinator on an interview, and 25 participants were enrolled and completed the interviews. For unclear reasons, although we recruited both hemophilia A and B, only those with hemophilia A responded and completed the interviews. And so some of the results are summarized here. So the age, ranged from 20s to 70s, so quite wide. And then we asked some sort of discrete questions about perceptions of gene therapy, key stakeholders in decision-making, key information needs. And in terms of the perceptions, 40% were excited about gene therapy, 48% hopeful, and then 4% worried or scared or without strong feelings. And then, as with the survey study, we found that key stakeholders in decision-making were the Hemophilia Treatment Center, as well as family and friends. And then the key information needs lined up with what I've discussed before. And so then from the, as part of the interviews, we asked about whether or not a shared decision-making tool would be useful. And so the majority, 88%, said yes, it would be useful. There were two who felt like they did a lot of their own research and really didn't think it would help them. And then one who needed more information. And then some representative quotes in terms of, sort of what should be included in the tool. One person said, enough for people to realize that this is their lives they're dealing with, and they need to be informed about what's going on so that they can have a hand in that decision making. I think too many people leave that research and information gathering and decision part to their doctors, and that's not good. And then in terms of what to include, just the effectiveness and the chance of the ability to actually participate in a study, seeing how long it lasts, see how many people have done it, how long it's working for them, and if they keep their factor levels up. And then more towards sort of the utility of a tool, one person said, having this with the medical provider when you're having the discussion, being able to write notes, taking it home so you can process it, kind of sleep on it, and then return to a decision later on. They felt that would be quite useful. So in highlighting the fact, again, this isn't a one-time discussion that ends in a specific decision. So then coming soon, related to a patient shared decision-making tool. I've been on a working committee with the World Federation of Hemophilia. It's a multidisciplinary group, and we're developing this tool. And it will have 3 types of modules: education about condition and treatment options, the information about how the treatment options might impact on life, both medical and sort of general life, and then consideration of preferences and decision making. So walking people through that. It will be online and interactive. There'll be scenarios that you can sort of see how a choice would impact outcomes, questions, an area for note taking, and then report to share. So this could be done on someone's own time and then brought in for discussion or sharing with the medical team. So there should be more out on this over the summer. So we talked a lot on the patient side in terms of education and decision making, and with any new therapy, then providers on the medical team need education as well. And there was an international survey demonstrated a lack of knowledge about gene therapy among healthcare professionals, including physicians, who are 59% of the respondents. 35% reported a lack of ability to explain the science. 40% were uncomfortable answering patient questions. And I think this is also reflected in what patients see. There was another survey where patients were asked about their perception of healthcare provider knowledge about gene therapy, and 26% reported that the providers did not have enough knowledge. And so now I move into the 3rd study of development of a clinician shared decision-making tool for hemophilia A. And the reason this is on hemophilia A is at the time that we were developing this, the only gene therapy clinical trial with data published in a peer-reviewed medical journal was for hemophilia A. But certainly one will need to be developed for hemophilia B, and these will need to evolve over time. But the study population included clinicians at U.S. Hemophilia Treatment Center. They were recruited through an organization, Hemostasis and Thrombosis Research Society, and then interested clinicians contacted the study team. And then we conducted interviews where the participants answered both open and closed-ended questions about demographics and clinical practice, experience with shared decision-making and gene therapy discussions, what they felt were key gene therapy attributes, and then utility of the tool. And then we actually share the prototype of the tool with the participants, and they provided feedback, including initial impression, recommendations about specific formatting and content, and additional resources to be included. So we had 10 participants, including 8 physicians and 2 nurses. Years of clinical experience range from less than 5 to more than 20. 7 had gene therapy at their sites. With confidence in discussing gene therapy range from none to high, although 50% had moderate confidence. All identified the utility of the tool, and then there were recommendations for the prototype regarding the language and presentation, the content, and implementation. And our results are under review for publication. So hopefully that will be published over the summer. And wanted to share one figure, or this word cloud. And so we basically, with the interviews, are transcribed and then analyzed using qualitative research software. And this word cloud represents our frequency of the key content and implementation elements that the participants discussed. And so you can see in the middle, one of the major parts of the gene therapy discussion is what's required for post-infusion follow-up. Like this discussion is not a one-time thing. It's not that you get your gene therapy and then never come back to the hospital. Other key issues, of course, were safety, including the need for immune suppression, efficacy, including durability, cost, psychosocial impact, and then clear discussion of other treatment options, and setting clear expectations. And so, we were able to take all of this feedback and revise the tool, and then that will be published online once the manuscript is published. And so just in thinking about next steps, so particularly as there are commercially available gene therapies, we'll want to evaluate the shared decision-making tool in practice. As I mentioned, we'll also need the tool for hemophilia B. There'll need to be provider training on the implementation, and we would sort of test this through assessing knowledge about hemophilia therapies and confidence in shared decision-making skills, and then evaluate the impact of the tools on patient knowledge, risk perception, and satisfaction with decision-making. I do want to acknowledge funding from the National Hemophilia Foundation, from BioMarin Pharmaceuticals, and then local philanthropy from Henry's Fund. And then just the last two slides, I have some resources for provider, but it's really for the whole community in terms of education through ISTH, NHF, WFH, the Indiana Hemophilia program has the Partners program with gene therapy modules, and then of course education through our industry partners. And then finally, this has some resources for shared decision-making for those who are interested in learning more about those details. So I'd like to thank you for your attention. I'll be happy to answer any questions. I'm going to go ahead and stop the sharing.
Great. Thanks so much, Dr. Thornburg. That was wonderful. We do have several questions that came in, and I'll start right at the top here. First question is, how will I know if my healthcare provider would be open to shared decision-making model? That's not something that we have really done in the past.
Yeah, no, that's a great question. And I think as clinicians, I mean, we do want to be, patient focused, but we have different styles. So I think the best thing is to ask the team, and I didn't specifically say this, but it's really going to be multidisciplinary discussion. So I mean, you can ask the physician or the nurse, the nurse practitioner or social worker, and I think just first bringing up the idea that you want to discuss new treatment options, and then asking if they're aware of sort of the evolving shared decision-making tools.
Great. Thank you. Next question that comes in. I see different people every time I go to the HTC. There's always a different doctor. Is this something everyone is aware of? Yeah,
so that is a great question as well. Yes, and sometimes the medical teams are quite big, and you can see different providers. I think that actually in the medical community, at a lot of our conferences, and even now published in the literature, there's more and more on shared decision making, and so to really make the effort so as many clinicians as possible are aware of it. But as a clinician in a rare disease, I'm always open to learning from others and taking what people bring to me. So I encourage you to, educate your healthcare providers if they're not aware of it.
Great. Thanks, Dr. Thornburg. Next question that comes in. I'm not necessarily interested in gene therapy at this time, but can I still, does that mean can I still participate in a shared decision-making with my physician?
Yeah, that's an excellent question. And yes, totally. Actually, one of the first times I became sort of familiar about this for hemophilia was a publication out of Canada where they had several tools for decision making about factor prophylaxis. It was a little bit more, these particular ones were geared more for children, because it was like when to start if you should start prophylaxis, if so, how and when. And then another set related to for those with inhibitors and decision making about immune tolerance. So and this is something that these tools and discussions are not prescriptive. Like we've talked about gene therapy, but it's in no ways to just like, the goal is not to convince someone to do gene therapy, but to be aware of all the possible treatment options and then sort of go through the education and goal setting. So and actually in the WFH tool, as people go in, select their type of hemophilia, A or B, and then can basically decide what they want to learn about, and then that would go along in like in the report and what they're thinking about in terms of the treatment attributes and their goals. So yes. It's across the board, and there's a number of examples even throughout other healthcare. Mayo Clinic has a lot. I know, like related to diabetes or decisions about different types of surgeries. Anything where there's more than one option, and it's not like clear cut in terms of what is the best treatment.
Great. Thanks, Dr. Thornburg. Good question that came in next. What if I make a decision with my doctor that my insurance doesn't approve? Then what?
Yes. So, I mean, that's, we're still in somewhat of the black box. I know that with the, hemophilia B product approval, there's, a lot of work being done with their insurance to ensure that there is coverage. I guess that if that was a specific case, there are like appeal processes that both patients and providers can negotiate or put more evidence towards the case of why you should have a specific treatment, or if it's not initially approved, potentially at some point it might be.
The next question that comes in, and I know Samantha Carlson is in the audience right now, and I'll ask her to maybe drop the link in the chat, but she had said, or she had asked, how do I sign up for CVR to participate in the research? And Sam, I believe there's a link. If you don't mind dropping that in the chat, it would be great. So I'll go through to the next question, unless you have something that you wanted to add to that, Courtney.
No, I really appreciate the question, and I think because the more people that participate, then the more we can learn, and particularly what matters to the community. And I understand that you can participate both if you have the bleeding disorder or if you're like a caregiver for someone. So it can include children and the whole age span.
Right, absolutely. The next question that came in is, do I have to wait for an opportunity to have a shared decision-making conversation at my annual comprehensive visit?
So yeah, another great question. So I would say no, because if you could have your comprehensive visit in February, and then the next month there's approval for a new treatment option, or something could just change in your life, and now you want to have the discussion. So I would just encourage you both to look for educational resources on your own, but definitely to reach out to the treatment center and request another visit for that specific reason.
Great. Another question that came in, let me find it here, I'm sorry. And this is the final question, Dr. Thornburg.
Okay.
They said, I'm interested in gene therapy, but I'd like to speak to someone who's had it. How can I go about that?
Yeah, so that, I've found that quite a bit in terms of, sort of having that, personal touch, and really to come to understanding of, what the experience has been for another person. So, I think to date, really a lot of, the people who've had gene therapy have been part of the clinical trials. This will change soon, but at least if your treatment center has been part of gene therapy, then you could ask the team if they could connect you with another, someone who's had it. If that's not the case, then if you're, involved through like your local hemophilia association, you may be able to, to meet someone that way. I think it's a little tricky, because, I'm not sure. I mean, some people use social media, but that could have some pluses and minuses. So I would at least start with the treatment center, and then even if your doctor hasn't had other patients with gene therapy, they may have colleagues that could help with connections. So hopefully that will become easier over time.
Great.
And if NHS has any suggestions, I put them out there too. I know that a lot of times now, like at the conferences, they're having, it's much more interesting to have the panels of people with the experience, so that might provide another opportunity if you can attend the conferences.
You actually read my mind there. I just got a thing from our education team that said at BDC this year, we will have some sessions on gene therapy where recipients will be speaking. And I just dropped another link in the chat there that will direct you towards that. So thank you for saying that, Dr. Thornburg. We put it in the chat there, and we will be having those folks at BDC as well too. Great. So, well, Dr. Thornburg, thank you so much for taking the time to join us this afternoon. We really appreciate it. Appreciate your time and your expertise, and just, many thanks to you for taking the time out of your day to do this for us.
Yeah.
Yeah, go ahead, please.
No, I was just to say my pleasure. Thank you for the opportunity, and yeah, great questions. So that I'm thankful for that as well.
Absolutely. So please note that the recorded webinar will be available on Friday, May 26th at hemophilia.org under the events tab with all of our other archived webinars. Also available in the events tab is all of the schedule of our upcoming webinars. So please feel free to jump on the website and take a look at that. Thanks again for joining us, Dr. Thornburg, and thanks to everyone else for joining us. Have a wonderful afternoon.
Thanks.